Hi, Richard.
To this session around the missing middle. I'm joined here by my dear colleagues Nadine Dougal and Chris White, and they'll be introducing themselves in a little while, and certainly through the video presentation that you're going to see today. Just before we start, I thought it might be a bit useful to lay out what the session is going to be around and how we actually got to this point of having doing this presentation. So through the law enforcement and mental health special interest group, we've worked together across a number of the conferences. This is my fifth conference for law enforcement and public health, and we had the joy of hosting the conference in Edinburgh in 2019. But in the conference prior to that in Toronto, we came together and did a bit of work that has then gone on to inform another meeting that we had in Edinburgh, which really brought together citizens, police officers, researchers, policymakers, practitioners together to start thinking about the impact of law enforcement, the emergency department and mental health. And out of that area of work, we really focused down on a specific group, which we have sort of conned the name the missing middle. It's a group of people who are brought to the emergency department by law enforcement, by police usually, but they're generally, do not require inpatient services, but actually what's available to people for support in the community isn't enough either. And so a group of people who are really not serviced incredibly well by the current systems. So we started thinking and working around that. We've recently been involved in developing a book chapter that on law enforcement and public health, and Isa Bartko-Vaktheron and colleagues have edited that. So the background to that work is really from this evolving conversations and discussions that we've been having. Not with us today are two of our co-presenters, Stuart Thomas and Danny Keswick from Melbourne, but they are presenting in this video clip that we're going to show just now, and they'll introduce themselves. It's because it's the middle of the night there and it was just too difficult. So they're presenting here. I'm going to show the video which has got all the presentations, and then there's going to be an opportunity to ask questions at the end of that. So I'm just going to go ahead and hopefully it'll all work and you'll be able to clearly hear the video presentation. First, we have Chris, and he'll be introducing himself through this. That's followed by Nadine, who also will introduce herself, then Stuart, then myself, then Danny. Thank you.
My name's Chris White. I live in Glasgow in Scotland. And thinking back to myself, Stuart, Inga, Nadine and Danny, starting this conversation about 2 years ago underneath the shadow of Edinburgh Castle at the last LEPH conference in 2019. Of course, back then, we were allowed to meet in bars and coffee shops and just have face-to-face conversations. Conversations around our different perspectives of what happens when life gets to a point where you feel it will burst, when you can no longer contain it, and then suddenly everything just kind of bursts out and you're a person presenting services in crisis. What does that look like for the first time? That point where you go from being another unseen person in the street, going about your normal day, suddenly being at the center of this thing. There might be police, ambulances, onlookers, or it might be dramatic. It might not be that dramatic, or it could be something just more mundane. But your mental distress has suddenly burst out into the world. what do we mean by mental distress? Over the last 30 years, we've seen an increasing global recognition of the prevalence of mental health conditions and the impact that this can have on individuals, communities, and economies. It's become more acceptable to talk about mental illness, or at least some forms of mental illness. Stigma, public perceptions can still make crisis and distress difficult, especially with such dramatic presentations, even traumatic portrayals in the arts and the media, influencing our behaviours. And there is no denying that at times, those crisis scenarios do play out in public, dramatic, frantic scenes. But the reality is that crisis can look far less dramatic. The flip side of that image of crisis is a growing openness to talk about having had a bad day, or that we're dealing with a difficult situation. And in those situations, we can find support. But there's another side, that bit where life wants to break down, where we might want to cry or even scream out in public. We have to question whether or not we're really open to talking about emotional distress over coffee. It is this group that we often see fall through the net. They fall somewhere in between. And because we miss the opportunity to do something, we don't know much about them. We have part of the jigsaw, but there is a whole missing middle. There isn't one image of distress, no one cause. Distress is highly variable, complex, and personal. Frequently, these episodes stem from significant life events or social causes: failed relationship, job insecurity, family conflict, childhood trauma. And some of us might be more at risk of crisis. Socioeconomic factors, systematic inequalities, discrimination based on race or gender can all increase our risks of distress. And for some, crisis might be a one-off short-term occurrence, although the severity of distress can vary. For others, they'll experience more than one, and often several episodes of distress over a prolonged period of time. How we first respond to crisis may have an impact on what happens next. But in a process-driven system, do we always respond appropriately? Or do we let too many people fall through the gap? So to give a personal example for us to consider, in my past, there's been several attempts to take my own life. And these didn't just happen out of the blue. There were missed opportunities. A time where I went to my doctor and said, I'm not coping, life seems a mess. Or a time where I took a few paracetamol and phoned emergency services, and then in the emergency department, begin to feel embarrassed, even guilty. When asked, I say I'm fine, it won't happen again, and then leave. Or a few weeks later, someone phones the police because I'm
Inga, you may need to go into share screen and click on the bottom where it says share sound and optimize. If you open up the share screen icon at the bottom.
look like when someone presents in
I can't see that.
distress in a time of pandemic.
Richard.
Oh, okay, we hear it again now. So
Might be wearing masks, trying to keep social distance, or looking to the future when we actually start socializing again, when places start beginning to open again, and we've missed that social contact. What does distress look like then, and how do we respond? There's some of the issues that we really want to dig into and explore when we look at this missing middle.
My name is Nadine Dougal. I'm an Associate Professor at Edinburgh Napier University, and I'm also Co-Director of the Scottish Centre for Law Enforcement and Public Health. Now I'm going to talk to you about how do people end up presenting to services with vulnerability with complex needs. And here we need to consider the role of multiple disadvantage or those social determinants of health. So strong relationships are well known between poverty and health inequalities. And the conditions that people live, grow and work are known as social determinants of health. And this was first written about by Marmot and Wilkinson way back over 20 years ago. The pre-existing socioeconomic inequalities in our society, which have now been exacerbated by COVID-19, has determined in the Marmot Review published just last year that we urgently need to address socioeconomic and health inequalities. And as with many high-income countries, the UK has experienced worsening premature mortality rates year on year in more disadvantaged communities for almost the last entire decade. So investment in public health is really vital here to mitigate those health inequalities. And this is particularly the case after the impact of the pandemic. In the UK, the key manifestation of severe and multiple disadvantage is that there are a huge overlap between three disadvantages of offending, substance using or dependency, and homelessness. And 2/3 of people using homeless services are also in the criminal justice system or are in drug treatment regimes. And that's all within the same year. To add to that, two further disadvantages, that of a mental health condition and domestic violence or abuse. And what we also know is that people who frequently experience 5 main disadvantages are predominantly younger men, and in the UK they're white men. That higher rates of extreme disadvantage are found in urban compared with rural areas. Vast swathes of the north of England, parts of London and Scotland are particularly affected. As children, many experience trauma and neglect, poverty, family breakdown, and disrupted education. And as adults, many suffer alarming levels of loneliness, isolation, unemployment, poverty, and mental ill health. And when you look at the overlapping populations, those who have experienced these things as children and as adults, things are considerably worse. Taking Scotland, which is where I come from, as an example, in a lifetime, an estimated nearly 1 million people in Scotland, that's almost a fifth, have experienced one of these 3 disadvantages in their lifetime of homelessness, offending, and substance dependency. And if we widen that lens to include mental health and domestic violence or abuse, we find that domestic violence or abuse is similar in scale to substance dependency and homelessness, both of which are larger than offending. However, mental health dominates in scale by an order of magnitude, with current cases estimated at 205,000 per year, or 4% of the general population. And although offending involves the smallest number of people, it also includes the highest number of people with overlapping forms of current severe disadvantage. And those routes into severe and multiple disadvantage are driven by poverty, violence, and trauma, and the trauma frequently stems from childhood adversity. And when we consider the role of early life adversity, what we know is that the studies of early life adversity and its impact on later adulthood is really well documented now. So back in 1998, the first study was published by Felitti et al., who reported that 4 or more adverse childhood experiences, or ACEs as they've become known, are linked to 4 to 12 times the increase in alcohol use, drug use, depression, suicidal behaviour, and suicidal attempts. And multiple studies have confirmed the relationship between those ACEs and a wide range of negative physical and mental health outcomes in adulthood. The strongest associations of multiple ACEs are for problematic drug use, interpersonal and self-directed violence, so that includes self-harm, sexual risk-taking, mental ill health, and problematic alcohol use. But we should also bear in mind that not all people are affected by ACEs in the same way, and that on average, circumstances can be mitigated through having beneficial childhood experiences as well. ACEs have also been associated with lower educational attainment, higher risk of depression, substance use, tobacco use, and those with 4+ ACEs are reported as having 2.4 times the diagnosis of depression and over 3 times that of substance use. However, this persisted even after taking account of family and socioeconomic factors. Although the links between poorer health and having 3 or more ACEs of domestic violence, parental divorce, and living with someone once incarcerated are almost entirely explained by poor socioeconomic circumstances, we know that ACEs that are derived from physical, emotional, or sexual abuse are associated with many adult health risks not explained by socioeconomic status. So what we find is that people have more complex needs and have more vulnerability because of circumstances that are through no fault of their own when they were children. Individuals with multiple ACEs living in disadvantaged communities exposed to continuously worsening social inequality face the most particularly challenging circumstances. This exposes people to economic uncertainty, and it also increases their likelihood of being exposed to the health and justice systems. And this is why a public health approach to health and justice is urgently needed. And we pay attention to the prevention of harm and addressing complex social issues in people's lives to stop the cycle of repeat presentation. People who present to emergency departments have frequently got ongoing unmet healthcare or social needs that could be addressed elsewhere. Community mental health care and primary care requires to be bolstered with multi-agency response to people with complex needs. In health, we frequently have multidisciplinary teams to tackle problems which don't sit within the silos of the health disciplines. And similarly, what we need is a multi-agency response in communities to deal with people or to support people better who are living with complex needs and complex issues. And certainly in the UK, as is probably the case with other high-income countries, after the banking crisis in 2008, austerity measures were implemented by the UK government, which has really eaten away at the resources that the charitable sector or NGO sector used to provide to people with complex needs. And this has further been exacerbated with the pandemic. And here are a few references that I've used in this presentation. Thank you.
Hi everyone, my name is Stuart Thomas. I'm based in Melbourne, Australia. The starting point for my talk is looking at police involvement in responding to mental health distress. So we all know that police have long played a central role in responding to mental health distress in the community. A recent UK report by Eddie Bawali suggested that police are providing a gateway to appropriate care. Others have said that it's really vital because the police decision-making determines the person's trajectory into the health or criminal justice system. Now, the police have a legal obligation to respond to calls for assistance 24/7. Some early work around about 20 years ago suggested that the police were the first and sometimes the only response available. More recently, myself and colleagues have said that responding to mental health distress in the community should be considered core business for the police. So what do we know? So police are there and they have a role in responding to mental health distress, but it's recognised now internationally that demands that this places on the police have reached what some have called, it's reached an intolerable level. So they're just saying they can't cope with the level of demand that there is. And that's even without being able to quantify the frequency of these calls to respond to mental health distress as well. It's something that's been really challenging. Some work that I've done with colleagues here in Australia suggests that up to 20% of police time is spent responding to mental health related incidents, and various other estimates internationally suggest between 10 and 20%. However, a recent report here by the Victorian Department of Health and Human Services suggests that this contact rates are likely to be much higher. And the example that they give is the police being required to perform welfare checks to locate a person to make sure that they're safe. So one of the things that's received particular attention is the issue of transportation. So the general sort of mantra is that police should only be used as a last resort to transport a person experiencing mental health distress to an emergency department. However, research suggests that this last resort is happening on a much more frequent basis than we like to see. So some early Australian work by Lee suggested that around 30% of presentations to the ED were a result of police referral. We've seen substantial increases when we compare data from EDs, so between 2003 and 2013. Perhaps more worryingly, some research that I was involved with a doctoral student here in Melbourne suggested that once the police become involved in any capacity, they're then the most likely service to be used to transport the person to the ED, regardless of if there's other services there. So here's an example of a recent report by the Australasian College of Emergency Medicine called The Long Wait. And you can see in the light green, the percentage of arrival modes to EDs for each of the different states and territories here in Australia. And while comparatively in Victoria, where I'm based, it's relatively low. You can see there's quite a lot of fluctuation between the different states and territories. And of course, a good proportion of this population of people who present to an ED will do so through other means, so for example, by themselves, and won't have been brought in by an ambulance or through police or other services as well. Now, once you get to the ED, you've got a real sort of challenge, because on the one hand, you've got the police saying, look, we want to get out of here as quickly as possible. They want to get back on the street and get back to, other core business that they can see. But then the ED staff, on the other hand, are saying, hold on a minute, this is a risk for us, and this is something that needs to be managed. So various reports have suggested that the wait time at ED is significant, and it's leading to a huge frustration, especially for policing services. A number of jurisdictions have operating now to a 4-hour limit for the person to be triaged, assessed, and then transitioned into appropriate care or follow-up. But some UK-based research published in 2018 suggests that the majority are seen within a couple of hours. Now, again, drawing on some local context information from our health service here in Melbourne, there's a mutual agreement in place that the police have to stay in the ED until there's no significant risks of safety or concerns for themselves or for other people. And so again, that's leading to frustration, because the police are suggesting that people that they're bringing in are considered to be a low priority for triage, and a large majority are considered to be unsuitable for admission to our public mental health services. But the ED clinicians, like I was mentioning just earlier, have a very different story to tell. And they say, look, we've got real challenges with our assessment here due to high rates of intoxication, for example. It's very difficult for us to conduct an assessment. We've got ongoing concerns about violence, about self-harm, potentially people absconding and that leading to an untoward incident. And there's also issues structurally with the design of emergency departments and the risks that they hold around keeping people safe as well. So what was really fascinating, I'm really pleased to be able to just report on this briefly in my speech today, is that we've had a mental health commission, Royal Commission here over the last 2 years that actually released its final report just a couple of weeks ago. And there's some really interesting things that have come out of that. So just on the left, there's a story which I tweeted from one of our newspapers, the title being "Emergency Wards Amongst the Worst Places for Mental Health Patients." And so there's a really interesting full report that can be accessed and released, and the details are there on the website. But there's a couple of particularly interesting things that I wanted to bring to your attention. So the report led to 65 recommendations. And our Premier of the state of Victoria here, Daniel Andrews, tweeted the next day, so March the 4th, Mental health crises are health issues. We need to respond to them as we would a heart attack or broken leg. That's why when you ring 000, which is our emergency number, for a mental health issue, you get an ambulance, not a police car. So fascinating that he's already committing to that 2 days after the report has come out, and saying that actually this is a health response. And you can see on the right-hand side here that the mental health crisis is going to be diverted to ambulance services rather than Victoria Police. So really fascinating to see that this level of commitments being brought into place. Some commentators are suggesting that there's some very real positives to be taken out of the Royal Commission, but to implement all 65 of the recommendations is going to take a lot of collaboration and a lot of careful planning as we move forward. So it'll be interesting to see how this space develops over the next little while. I just wanted to leave you here with a few references, including a chapter that some of the presenters on this session have written together that's coming out soon. Thank you.
Hi, my name is Inga Heyman. I am a mental health nurse and I am based at Edinburgh Napier University. I'm also co-director of the Scottish Centre for Law Enforcement and Public Health with my colleague Nadine Dougal, who you've just heard from. I'm going to spend a little bit of time building on the previous presentations and think a little bit about the gaps in the system, criminal justice and health systems that may contribute to scenes like this where we see a large amount of police officers transporting people to the emergency department, and for the most, people will be returned home and they will not be admitted to hospital. So thinking about that scenario that people are sent home, there is an argument that the system is indeed broken. And in fact, that the criminal justice and health systems can actually contribute to harm for people who are help seeking and mental health distress, that it can be incredibly traumatizing because the system is not necessarily suitable to their needs. When we look at that, often it's because people find that they're sitting in no man's land. They're not quite sick enough to be admitted to hospital, but they haven't committed a crime either. So in clinical environments such as the emergency department or out of hours GP services, or indeed unscheduled care mental health services, they are set up for time critical emergencies. Often mental health distress is not seen as a time critical emergency, so often people will not be a priority in those clinical areas. Equally so, police services are not set up to deal with people in mental health crisis either. Certainly a custody suite is absolutely the wrong place to safeguard anybody in mental distress, and certainly that environment would certainly make things a lot worse for people. So we have people who, there's a situation that we're a bit of a double-edged sword here. People are brought into the emergency department by police, often viewed not as being time critical unless we medicalise it. So unless it's an overdose or somebody needs to have a medical admission to hospital. And we know that the ED environment is not conducive to good mental health care. In fact, it can make things worse. It can make people more agitated, particularly if there's been long waiting times. And we know that substance use intoxication can exacerbate difficult situations. People often don't reach legislative thresholds for hospital admission, or indeed for multi-agency community-based adult support protection legislation. And so they're not necessarily going to get the service through legislative thresholds. And that can lead to real frustrations within healthcare services and law enforcement services, because people are slipping through the gaps, but often we're finding the system is contributing to these cyclical distress systems. So we've got double-edged sword, poor experiences for people where there's nowhere else for the individual to go, but also nowhere else for police to bring people to. So Working within a binary system of criminal justice emergency healthcare, there's a real conflict at play here. Police are working incredibly hard to keep people out of the criminal justice system, but equally so, healthcare staff are working incredibly hard to keep people out of hospital, to prevent medicalised and mental distress when there may be no serious mental illness. And also, we know that long-term harm can be caused by inpatient care. So actually, people are just falling through the gaps, but within those gaps, police and health services are having to work within those gaps. And often the way that we work can actually contribute to the gaps in the system. So police and health services can be really motivated in our practice quite differently, to the point that we're working in opposition. So an example of that is that, you know, we've got very different professional perspectives of what individuals' needs might be. There's a tension between the real risk-averse approach to mental health by police officers to a much more risk-positive approach by health services when we're you know, really looking towards recovery and to keep people safe, rather than taking a risk-averse approach. So working within these gaps, we can see that individuals, police, healthcare professionals find that they need to work around the system to manage distress for some people. And we know that people with mental distress will often call the police as the first point to call, because they know that they're much more agile and able to come quite quickly when their distress is escalating, rather than health services. It's particularly difficult when we see people exposed to really long wait times, particularly if they're intoxicated, that they can start to feel really entrapped and frustrated. And this can lead to aggressive behaviours. Often the aggressive behaviours will result in people being arrested in safeguarding custody, just as a result of being really aggressive. Adding on to that, that police processes such as using handcuffs and in strip searching policies within custody can really reinforce distress behaviours and aggressive behaviours. So indeed, we're just, you know, re-encouraging the cycle of distress. When we think about redesigning services, there's a real need to consider the relationship between people's distress behaviours, the gaps in the systems that we have, and the human responses to these gaps that can really contribute to these repetitive distress cycles. The harm that we cause to people, such as re-traumatisation, stigma, and a lack of dignity, because we're pushing them into a system that's really not designed well for their needs. So just on that ending point, I just want you to think about how we fill those gaps. It really needs to be a person-centred approach that finds the right care for the people at the right time, at the first time, that minimises the distress cycles instead of encouraging them. And one of the things I want, you know, it's worth thinking about is that in Australia and Scotland, that there's a real commitment to reimagining what collaborative services would look like. I would encourage you to attend one of the sessions tomorrow. My colleagues from Police Scotland are presenting on the enhanced mental health pathways that's been redesigning Police Scotland's approaches to mental health distress. On closing, I will leave these references and I look forward to your questions.
Hi, my name is Danny. I'm a researcher and psychologist from Melbourne, Victoria. I'm going to talk to you about what we know so far about how the pandemic has been affecting people's mental distress. I'm going to look at what's been happening in Australia and compare that a little bit to what we know has been happening in Scotland. So here in Australia, we have been in somewhat of a unique position because from months prior to the pandemic starting, so we had our first case in February 2020, we had a significant environmental disaster. We had bushfires throughout much of the eastern coast of Australia. So, you know, we can say that people were already had heightened levels of anxiety dealing with this natural disaster. On top of that, we have what the Royal Commission into our mental health system, it is something called a mental health system that had catastrophically failed the community. And it was unprepared to deal with current and future challenges. So I guess it's no surprise in a way that when we look at formal data from the Australian Institute of Health and Welfare, we found that rates of distress, psychological distress, depression, anxiety, loneliness had increased from 2019 to 2020. So people were reporting much higher rates of depression, anxiety, and psychological distress during the pandemic as compared to prior to the pandemic. Importantly, this formal data is also suggesting that there have been no changes to the rates of suicides. However, we know that it's really difficult to study suicide in real time, and more recently we have some more mixed findings coming out. Again, significantly, we don't have data on people presenting to EDs in distress, in psychological distress, and mental health distress. So that's a huge gap in our knowledge so far. So what we have when we look at what initiatives have been put in place in Australia to help people cope, there are quite a number of them. I'm just going to highlight a couple. The first one is the establishment of head to health multidisciplinary team hubs across the state. The reason why this one is important is these hubs were one of the main aims of establishing them was to address this missing middle gap. So that people can access mental health quicker and more efficiently. We want to know, however, how successful they've been. They've only been established for a year, and there's some suggestions to say that we need at least 100 of these to actually meet the demand that's there, the need that's there in the community. Importantly, there have also been a number of non-health initiatives like government stimulus, economic stimulus packages. And a lot of people have claimed that there have been some studies as well to say that they have had a very significant impact in assisting people coping and reducing their distress during the pandemic. When we look at Scotland, there's a Scottish COVID-19 mental health tracker study. This study importantly says that over the duration of the pandemic, the rates of depression and anxiety have not increased. And if anything, people are reporting less mental distress as the pandemic wears on. However, especially youth are reporting an increase in suicidal thoughts. What we want to know is a more updated, we want to know about updated findings of this study. So they are about to release data on what's been happening most recently with the toughest lockdown in Scotland. How has that affected people? There have been a number of initiatives in Scotland as well, and I only wanted to highlight the third dot point, the establishment of mental health assessment centres separate to the EDs. Now, the special interest group and others have advocated for alternatives to EDs for quite a long while, as we know that emergency departments are not the appropriate place and for people to attend, for people who are in mental distress to attend. So I know there are people on this presenting at this conference who will be talking about this exciting initiative, and I can't wait to hear about what they've got to say. So overall, what do we know about rates of mental distress and how the pandemic has affected it? In a way, we don't know much, and we need to keep monitoring the situation. So there are some things that we can say with a bit more certainty, such as initially, the pandemic led to increased levels of depression, anxiety, and mental distress overall. We need to know more about how has this changed and what has impacted on people's mental health throughout the duration of the pandemic. You know, when we look at findings and studies on other environmental disasters, we know that over the duration of disaster, and so the acute phase versus the more longer term duration, people respond differently. Specifically, there will be an effect on people of the government's pulling the initial supports, the very significant supports. So once the government pull this back and scale this back, and we've got a few initiatives are about to end here in Victoria in the next couple of weeks, we can hypothesize that that's going to have an effect on people's mental distress. So we still need to monitor the situation. And whilst we do monitor, I guess we have all the more reason to keep advocating for the improvement in the mental health system. It needs to be able to respond to these challenges. We need a comprehensive system transformation. We need to keep advocating for it. So watch this space. Thank you.
So, oh, am I on? Yes, I am on mute. So I might just ask my colleagues to come back. If Chris and Nadine can both come back, that'd be fabulous. We've got 10 minutes to ask questions. I see there's quite a lot of them in the chat already. And so we'll have a look at those. Just for Danny and for Stuart, they've, because they can't be here, they've extended the opportunity if you want to contact them directly about any questions that you might have, or if you'd like me to pass on the questions to them, I'm very happy to do that because they're not here in person to do that. So I can do that. So just look, and you can either sort of raise your hand, you can put some questions in the Q&A or in the chat. Lots of questions there. Does any of my colleagues see anything that they would like to respond to at the moment? Chris?
I'm just coming on one point that's relevant to emergency admissions, Inga, and it's kind of in response to a point that Elliot made, and I've witnessed this quite often when I've worked in the US, is, you know, where someone knows that they're in distress, but has very, very low levels of health insurance, and therefore doesn't access services, and particularly doesn't access services that would require a paramedic and ED attendance, because actually they're going to get a huge bill for that, which is a massive barrier to receiving help and treatment.
From the financial perspective, Chris, yeah.
Yeah, I mean, you know, some of my hospital, some of my crisis hospital admissions, and particularly my compulsory admissions, had they been in Florida as opposed to Scotland, they would have bankrupted me. And I spoke to a number of people in the US, and folks in the US will say they know a number of people who essentially have been bankrupt by being in psychiatric distress, and there's very little option for recovery when that happens.
Yeah, and here's us speaking about the NHS, you know, which are a fantastic service, but it's still not right for that group, isn't it? You know.
Yeah, at least it's not a hostile environment for people who have psychiatric conditions.
Yeah.
Or that kind of sub-threshold that we were talking about, the missing middle. So people might not have a diagnosed mental health condition, but they may have symptoms of distress, which also requires attention.
So I'm just, is there any, I'm looking in the chat, but you're very welcome. Anybody that you would like to put your hand up. I can't see any raised hands. There is a message there.
Just respond maybe to a point that Richard made earlier, which was around examples of individuals. How are they managed once they're in contact with health services? Is there any data around that? And I think that's the holy grail, a data-driven approach to this, so that we could understand what happens to people. And second to that, if I can draw on some findings of our research, which is forthcoming, which is around, we've looked at hospital contacts for people along their lifespan before they died by suicide as young adults, and what happened along their lifespan, including looking for childhood adversity. And what I can say is that there is no typical pattern of childhood adversity and then mental health condition and then suicidal behaviour. You might hypothesise that might be the order that it happens in, but actually we found no specific order at all. And further, the people that were most affected were adolescent boys who were presented to emergency services as a victim of violence, so assault, and that in itself is a massive risk factor for later suicide in comparison to the general population. So I could talk about that a bit more, but I don't want to hog the slot.
There's a really good point that that someone's popped up here, which I think it's so important, that people often think that being offered the hospital treatment instead of jail or prison, or or cell block is actually should be really positively received. What police and many other people don't understand, that it's really terrifying experience for people to be within a psychiatric facility. And so, I mean, that's such an important point, and I was trying to speak about that earlier on in my presentation, that we kind of miss a bit of a conversation there, that we're kind of pushing people between two sort of binary systems, between, mental health, psychiatric systems and criminal justice. Actually, neither are probably right for some people. And so, and both are terrifying for a lot of people. So it's a really, really good point. Sorry, that was from Jennifer Chambers. And sorry, your name didn't pop up, but thank you, Jennifer. Is there anybody else, Nadine or Chris, that you're wanting to pick up on any of these points here?
You're on mute, Chris.
Yeah, you're muted, Chris.
Someone had to be on mute. Yeah, looking through the chat as well, I think, one of the things that strikes me as well is that we often describe having a mental health condition as disabling. I think my experience and when I talk to other people is that actually getting into that system and the way that system kind of dehumanizes you is far more disabling than the mental health illness element was.
And I think that's a really important thing, the dehumanization of the system to people, how undignified it is to be cuffed and brought into the emergency department. And I know, having worked in the emergency department as a nurse, seeing somebody coming in cuffed, you think, oh God, you immediately think it's crime related, where it couldn't be further from the truth. But it's so undignified. And I know that there's so much work going on. I was so privileged to sit in one of the presentations today around the crisis intervention work that's happening, CIT work. And it's so, there's such opportunities for change. But I suppose we're talking about it, and that's really good. And as we've said in our presentation, that there is a real commitment for change, particularly in Australia. And I know from a Police Scotland perspective, there's such commitment for change and innovation. So there's it's better, but we're not there yet. I'm just wondering if anybody has anything that they would. I haven't seen any hands up or anything in the Q&A buttons. It's just in the chat. So I'm conscious that we've only got 1 minute left. I would really, we've got our special interest, the mental health, law enforcement and public health, mental health special interest group get together, mingle, we're calling it, is on, well, it's nighttime with us, but it's on, what time is that on? Do you guys, in the US time? I'm not.
2 hours from now.
2 hours from now. So you're most welcome. We're really keen to think about how other work we can develop, how we can develop some of the work for the conference, the next year's conference. And so we would really welcome anybody there to the mental health, law enforcement and mental health special interest group. We're really keen for people to come along. So please reach out to us as well if you'd like to join the group and you can't come to the session. Please just add your name in this chat and we can contact you and reach out to you. So that would be fantastic. Thank you so much. I know I've promised that we will have a really hard stop on time. So I'm going to thank you all for attending and coming along, and thank you also to our wonderful presenters. And hopefully we will be in contact again soon. Thank you.
Thank you.
Thanks so much, everyone.
Thank you, Richard.
Anytime. Bye, everyone.
Bye. Hi, Alki.
Oh.